I wanted to just start by summarizing. These are the kind of the three things I hope that we can talk about today. And I hope to stop early so we can have dialogue and discussion, and we can learn how to do this together, because there's a lot of wisdom in the community. And it's important through the Wisconsin idea that we engage and we listen, and we then use our expertise in service of the collective consciousness that we create together. And so we're going to talk about the people. We're going to get a little bit into payment, because that's usually what moves the world, and how do we strategize within that. And then we're going to talk about the process of how we go about doing this work together. So let's talk about our people and how we started this program way back in 2001. I have a couple of the founders here in this room. Mike Johnson was at the table, as well as Catherine Bonus, the head of the mindfulness program, and Jackie Kuda-Bangsberg and Brad Sherman. And we were upstairs in a room right there over there in the corner, and we said, what do we want to build together? And we initially realized that we have to build bridges, that we can't come in and just start talking about mindfulness and acupuncture, things that weren't part of the culture of traditional healthcare, without building bridges. And those bridges that we built were mainly built on trusting relationships and, frankly, science, because we're in an academic health institution and we need to talk the language of science. And if we can show the science of how mindfulness works, and we'll talk about some of these studies as well, if not better, than a lot of the drugs that we use for depression and anxiety, we're not going to get buy-in. So a lot of why I think we're still here today is that many of you have been really good at connecting these bridges. And then how do we walk over that bridge together? And then we realize, we may not feel like we've made a lot of progress, but we have. We have in these past 25 years. And we still have more work to do. One of the first things we did was invite Andrew Weil and John Kabat-Zinn to come and give a talk, and we sold out the Union Theater. $50 a ticket. We lived off that, buddy, for a good, we might still be living off that. No, it's gone? Okay. But this was a great time to really bring into the consciousness that, hey, we want to do things a little bit differently. We want a different process of care. And then we went on retreats. And these were a lot of our community way back at the beginning: massage therapists, acupuncturists, mindfulness teachers, clinicians of all sorts. And we retreated. And the beautiful thing about retreat, it gets you out of your culture of expectation, and it gives you permission to feel and think a little bit differently. We did this thing here at this retreat. I was talking to Mike just a second ago, called myofascial release unwinding. And it was the most educational experience I've ever had that I still can't understand. But what it was is we just got around, and one person just fell into the arms of the rest of the people and was completely held with support, love, and compassion. And the unwinding was the body just felt permission to move in ways that were freeing, frankly. And it allowed this freedom of movement through this physiome, this collection of cells, that allowed the heart to open in ways that I haven't experienced before. I can't explain it. I can't put science to that, but I know it required this entanglement with other kind human beings that gives us permission to grow in new ways, to grow and expand and change our understanding of this mystery that we call humans in nature. That's all interrelated. We're going to talk more about that. We did fun things. We explored with enlightenment. Mike, I think that's your head in that hole. I don't know. Maybe it worked. Mike's quite an enlightened guy. But we had fun, right? Life's too short not to have fun together and laugh. Brent, I think this was the retreat that you sang at. Yes. So Adam Brightflesh was our first fellow. That's Adam right up there. We're a bunch of tree huggers. And we explored this together. We're still exploring this together. And we cook together, we come together in community, and we try and figure this out. We had a program, we brought a lot of different professionals, interprofessionals from across the university to explore what it means to create a culture of salutogenesis, salute health, genesis, origins of. And we asked 3 questions. What does a community of salutogenesis look like? What does a clinic of salutogenesis look like? And what does that mean for the individual? And we brought leaders from all over campus to explore this together. And that was fun. We wrote it up in this iBook. And then shortly after this, Tracy Gaudette, who was working at the VA, called us up and said, hey, would you like to help train the largest healthcare system in the country about whole health, about how we change the conversation from what's wrong with you veterans to what's right with you veterans. We went to over 50, after I went to New Mexico, it expanded beyond that, clinics across the VA system, across the nation, to actually influence how we can focus and bring a better balance to our pathogenic model with more salutogenic focus. And now the National Academies of Science, Engineering, and Medicine have adopted whole health as a key initiative for how we influence healthcare in our country. That's exciting. And then shortly later, this very kind soul, Bernard Osher, was kind enough to include the University of Wisconsin with 11 other Osher centers across America and Sweden to be part of this collective consciousness of how do we lead this process further into the future to bring more salutogenic balance, to bring more value-based care. And so a deep bow of gratitude to Bernard Osher. Also gratitude to Sal and Judy Troya. Sal passed around this last year, but Sal and Judy have been tremendous friends of this program, have sponsored grand rounds, and just as Sal moved on and went on ahead, I like to say, this last year, he's riding his bike in the sky. A deep bow of gratitude to the Troya family as well. So who are my mentors? A lot of you and a lot of my patients. These patients gave me permission to use their images. They've all gone on ahead. This gentleman's name was Gizmo. There are 3 people. Gizmo was one of them. His claim to fame was he dated Shirley Temple in the Army. So had stage 3 heart disease. I had him on all the drugs for congestive heart failure. He would get short of breath walking from one end of the room to the other. I think many of you have heard this story, but I love to tell it because makes me smile. But once a year, he would dress up as our town Santa Claus. And he would throw a bag of toys that he would hand out to the kids along the street and carry his donkey through the town, so proud to be our town Santa Claus. And I knew his heart function. He shouldn't have been able to walk from here to there. He walked the 4 blocks of our main street with the biggest smile. What was it that overpowered his disease that should have prevented him from walking 4 blocks? It was the meaning and purpose of I'm the town Santa Claus. Don't underestimate the power of how that feeds this whole process of care. There was another neighbor of mine, Mr. Henry, sweetest guy you've ever met. He had a severe stroke that was going to take his life. The stroke affected his phrenic nerve, and he had these intractable hiccups. And we knew he was going to die, but he couldn't get any rest because he had these intractable hiccups. So I gave him all the drugs. I gave him high doses of Thorazine. That's an antipsychotic that paralyzes the phrenic nerve, but it didn't work. Yeah, all I did was sedate him, and so he couldn't be in presence with his family as he passed on. The family said, Dave, what about acupuncture? I kind of giggled. a little overconfidently, that, hey, if Thorazine doesn't work, acupuncture sure as hell isn't going to work. One treatment, his hiccups went away. He was able to consciously die in the presence of the loved ones around him. Whew, maybe there's something to these other therapies. I had another patient. This wasn't him, but they just make me feel good. They were old patients of mine. He robbed the cradle. She was 93. He was 81. And a rancher type patient like this came in, and I did a prostate exam, and there was a rock of prostate cancer. It was a big rock too. So I said, hey, we'll call him Joe. I'm going to refer you to the urologist. The hell you are. And he said, I'm going to take care of this. All right, Joe. And then he went and he did something about it. And he came back 6 months later. And I never would have believed this if it wasn't for my own finger. I did his prostate exam and I did not feel that at all. And I said, Joe, what did you do? And he was all excited. Let me tell you, and he brings out this scroll of about 300 things he did that I would never be able to understand what it was. But that story helped me remember a book I read in my fellowship about people who had remarkable recoveries. The author wanted to see, was it high dose vitamin C? What was the one thing that resulted in remarkable recoveries for that condition that often doesn't get better? And there was 3 things. One is that people often were stubborn. They didn't take no for an answer. So they were able to have the autonomy to make their own decisions. Number 2, they were malleable. They were willing to get out of their stuck belief system and shift. They were able to adapt to the environment around them. Number 3, they were surrounded by a loving social community. That was Joe. I'm not sure what cured his prostate cancer, or at least reduced it quite a bit, but he had all those 3 things. How do we do that for each unique individual within the context of their lives? That's now known as the exposome. The exposome is the soup that surrounds the genome. It's that epigenetic positive or negative hits that our body is exposed to throughout its life. We've actually shifted precision medicine to understanding the exposome here in the University of Wisconsin. So new names, same process, but how do we use these new names to move this forward? So these were some teachers of mine that I'm very grateful for. There's been a lot of names. Have you heard of these names? Holistic medicine was even before complementary and alternative medicine. This is what the public said that we needed to focus on because they were getting a little frustrated with a pharmacy dominant system. Then came integrative medicine, then came functional medicine. Now there's lifestyle medicine. We're talking about whole person medicine, but the process is the same. These names don't matter a whole lot. It's the process of understanding how we can facilitate health within complex systems. So let's explore that. Just during Lisa's meditation, this is the least exciting part of the talk, but it's really important. It's really important when we look at how we're doing in American healthcare in regards to, are we getting our money's worth? So the purple is a per capita spending, and the blue is a life expectancy. So you could actually look at this as a value-based slide. Are we getting our money's worth? Obviously not. We're we have some of the shortest lifespan, and our lifespan is actually shortening, not lengthening, but we're paying way too much. Has anybody been to Andorra? Anybody? Me neither. I looked it up though. It's a little country between France and Spain. And for a whole country, they have one jail. They eat a Mediterranean diet, as you might expect, and there's strong social connection. So this isn't just about healthcare, it's the whole society. It's the how do we work and support and work in harmony and with one another. But this is the challenge. Any ideas why this is? I would argue that our product for profit is disease. And when our product for profit is disease, subconsciously, what do we want more of? And that leads us to this challenging financial model. What's the number one cause of bankruptcy in America? Healthcare, right? So this not only is dysfunctional, it's actually causing harm because as many, myself included, would believe that the ability to attain our health should be a basic right for every human being. Patient gave me this button. If your doctor sees, I think I saw 30 patients that day. It's no wonder you're sick. But we have this tension between transactional care and transformational care. The market wants more transactional care. It wants us to see more patients. It wants us to put people into widgets that aids the financial model. But what feeds us or what leads to burnout? What leads to burnout is if we're doing more transactional care and we don't have time for transformational care. Because what feeds us in this work is that human connection, that human entanglement, we'll call it, that really facilitates health in both parties. Not only the people we're serving, but also us. So how do we make room for that transformational care while we also need to address the transactional care that's all around us? Have you ever explored Amazon Clinic? There's about 43 boxes that you can click on, everything from conjunctivitis to COVID. There's one for growing your eyelashes. I'm not sure that's what we need to really improve the health of humans, but that's where the market is bringing us. It's accessible, it's quick, and people get what they want. So that's not going to go away. That will be served. I guarantee you. This may not. That transactional care may actually erode the transformational care. And this is where healing happens. This is where fixing happens if we can. The majority of things that we see can't be fixed because they're chronic conditions that took time to develop and take time to reverse if we catch them early enough. One of the challenges is that transactional care encourages a pill for every ill model. And that pill for every ill model is not only a good thing because pharmaceuticals are one of the strongest medicines I prescribe, but there's also a risk when we overuse it. So a pill-centric model, polypharmacy is defined as 5 drugs or more. Once we get to 5 drugs or more, we start to get really confused on the interactions of all these drugs. And we just simply don't know how that's affecting the human body. Sir William Osler said, it's the physician's duty to educate the masses not to take medicine. How do we do that? Or how do we get people on the most appropriate medicine for their context or their condition? 36% of people over 65 in 2011 were on 5 drugs or more. That's increased to almost 44% in 2018. I would argue it's probably up to about 50% in 2025, 2026. The NHANES cohort showed that about 18.5% of people on drugs for hypertension were also on drugs that cause hypertension. We see that with dementia and cognitive decline. We put people on Aricept, which is an anticholinesterase inhibitor that increases the memory hormone, acetylcholine, when we have people on a bunch of drugs that have anticholinergic effects that reduce acetylcholine. So we're getting at a point where we might shoot ourselves in the foot. The first thing I do when someone's having trouble with their memory is I go through their medication list and I take them off all the medicines that have anticholinergic side effects. Before you would put them on a medicine that tries to increase acetylcholine, we want to remove what might reduce it. This meta-analysis, about a 54% increase the longer someone's on these drugs at a higher dose. We don't want to be causing dementia. We want to prevent it. So these are some of the challenges. How about low back pain? This was just published in the BMJ a couple months ago, which kind of gives me mixed feelings. I'll tell you why it gives me mixed feelings. Because as a primary care doc, we're trying to help people. And one of the things that we offer is, hey, you've been suffering for a long time. Let's try an epidural steroid. The BMJ says there's strong evidence against epidural steroids for pain that's lasted for more than 3 months. We now know from the MRI studies that chronic pain goes from the sensory cortex of the brain to the limbic system, and it becomes more emotional. So an epidural steroid after that more emotional pain is not going to fix that problem, and that's what the research is showing. The reason I'm mixed on this is because if I want to stimulate self-healing, I might order an epidural steroid. Why? We're going to do something to reduce your suffering. I'm going to send you to this hospital on the hill with a lot of smart, caring human beings whose sole intent is to relieve your suffering. And then I'm going to poke you with something sharp. Generally, when we poke you with something sharp, that activates the healing response, right? And then hopefully you're going to get better, and often they do. But when you do good science, you start to realize that does not last. Epidural steroids last for about a month, and then rarely do they continue to work. What does work? The National Institute of Clinical Excellence says these things work the best. Group exercise programs. Why don't we have more of those? Is it the group or the exercise? It's probably both. Manual therapy, massage. And then we bring in the mind-body piece. Psychological interventions seem to work most for chronic back pain. Jonathan Takahashi offers pain reprocessing therapy here. I understand there's a long wait list for that because it works. We have strong evidence to show that if someone's in chronic pain, it's probably not the nerve impingement anymore. It's complicated. There's other things that come in that we can't explain, but we have to explore that mystery of the mind-body spiritual connection to really get at the root. University of Vermont had a PATH program where they showed that a multimodal approach significantly improved the severity of pain. Greta and Andrew Kronbeck and others are exploring, could we start a similar program here at the University of Wisconsin? That costs $2,500 about. A epidural steroid costs about $2,200. What's the difference between this? This and this. This works. The other one doesn't. And this actually influences healing in the future. Part of the challenge with the finances of healthcare is it's myopic. If we're struggling financially, and we're experiencing this here at most all health systems, what do we turn to try and get out of the red? We turn to those procedures that make the most money the quickest. When we look at the science of value-based care and how we do this financially, it's a long haul. It's at least 2 years or more to show benefit. No one is patient enough. This happened with HMOs. HMOs failed because they got to the point where they just needed to save money now, and they weren't in the long haul game. So that's why I personally feel that this isn't going to happen if we stay in this business model. We have to have some sort of universal coverage. And then there will always be opportunities for people to pay more for health insurance beyond that. But we need to give every human being a basic access to good primary care that includes this process. The TAME study, this is about 270 people who were treated with mindfulness versus escitalopram, a serotonin reuptake inhibitor. One is active, it requires active participation of the human being. The other one is passive, I just pop a pill. They both worked after 6 months. Look at the side effects of mindfulness. There was anxiety. I don't know, Lisa and Catherine, you probably realize that if someone's really like not to say all engineers are like this, but if someone's really used to being in their mind and you tell them to get out of their mind, that can trigger anxiety. So how do we tailor that? There's a lot more side effects to escitalopram. So we have two therapies. One's active, one's passive. One actually changes the insight of that human being. The other one really doesn't. It just is a passive recipient of a care. Which one should we invest in for the betterment of, I'm speaking to a biased audience, but hopefully maybe someone who doesn't believe like we do is also listening. So we have that cognitive diversity to encourage us to all think a little bit differently. Patricia Herman, she's been doing this work in integrative medicine for a long time. She's an economist, really smart individual who I've learned a lot from. She put together this thought experiment that what if we took a human being with a number of health symptoms and we brought them through one of two approaches. The first approach is the traditional reactive pill for every ill. Here, let's give you a treatment for each symptom that you're having. And then the whole person care is, hey, let's do more of an engagement, empowerment, early non-drug interventions to really empower you to facilitate insight that results in better health outcomes. She then projected the average medical spending, that's the MEPS average for most humans in America. And when she plugged in all the numbers for the conventional approach versus the more salutogenic approach, this cost was 15% of this. Now, what's the risk here in our current model? The profits are 15% of this, right? So how do we create a profit structure where this makes money? And that's what we're talking about with a better balance between pathogenesis and salutogenesis. All right, let's end with the process. This is the fun part. Because we've been talking so much about the therapy or the vessel or the ceremony that happens before that therapy is prescribed. I think we would all realize, and we see this in psychology research. It's not necessarily the technique that the psychologist uses that works. It's a therapeutic trust with your therapist that generally works. So how do we create a process? That's why I love being a primary care doc. We make money taking care of our friends. and it's an honor to sit with them and work through some complexity. The other big benefit of having a strong primary care infrastructure, it reduces fear. If you want to make money in a capitalistic healthcare model, create more fear. Fear makes us do things. Oh, what if? What if it's this rare one in a gazillion disease? We better do those tests. No one's going to argue with that. But if I know Betty, Joe, Mark, I know them and they trust each other, we might not do that. We might say, hey, let's do these other things first. Let's address this stressor, see if your symptoms go away. And if not, we'll then go up the ladder of more aggressive things. We call that the primary care ICU. I will see you next week, right? The challenge now, since we have so much demand and little supply, is I can't see you next week. I can't get you in. So what do we need to invest in to really have that foundation of care that results in less cost and payment and suffering, frankly, into the future? We need some conscious awareness to look farther into the future if we're really going to do some policy changes that make a difference on improving the health of our people. So you probably heard a lot about health span and lifespan. This just kind of simplifies it. We want this to be as long as possible. And then you die, right? We want you to live as long as possible and then you die. So you want this to be very, very short. The best example I have of this is Queen Elizabeth. This picture was taken 2 days before her death. That's pretty good. Why did she have such a long health span? She's a queen. She was treated like a queen. Now, this is a really important point. And my colleagues, Shelley Shaw and others in our Office of Community Health have really helped me understand the importance of this. We talk about lifestyle habits or lifestyle behaviors. Some people can't choose those habits or behaviors. They are set up to fail in regards to their potential to be healthy. They may be a single parent with 3 kids with 2 jobs, and all they can afford is McDonald's. So that's why this is more than just saying, hey, we just need to behave differently. We need to create a culture where those behaviors are easy for most human beings. And that's why our department focuses on those more vulnerable populations. We're so proud to have that as our focus, is if we're going to raise the water for all boats, how do we address the most vulnerable populations first? And that's a key ingredient. So lifestyle and genetics, and this is a fun thing to realize, that 8 versus 0 positive lifestyle capabilities, let's call them. I think that's a better word, capabilities, than habits or actions, because not everybody can do them. But you might imagine what these are: don't smoke, exercise, good nutrition, optimal weight, no depression, good sleep, normal cholesterol, normal blood sugar, and normal blood pressure. There's some more. If you do those things after age 40, you add 24 years to your life. In this study, guess what percentage of people actually did all of those things?
0? Sorry.
I appreciate your pessimism. 3%. You're not far away. Actually, that was a pretty good guess. But look at the potential, right? That if we could, 24 years to someone's life. And what we're learning now is that lifestyle is much more important than genetics until age 65. If you can get to 65 relatively healthy, you're more likely to get to 100. If you can't get to 65 that healthy, you're probably not going to make it to 100. After 100, it's all genetics. It's mainly all genetics. Jean Calment, the oldest living human being, she lived to be 122, 121. She had a quote. She said, "I have only one wrinkle and I'm sitting on it." She smoked. She smoked like a tank. That's genetics. For most of us human beings, we want to try and maintain our health as best we can. Sometimes you can't, life, right? So this isn't always easy. But if we can do all we can to maintain health until 65, we're more likely to get to 100. Now, what influences our 65 to 100 the most? Stability, not falling. Now that I'm 61, I'll just stand on one foot, right? Or I'll do a deep bend. How can you maintain your stability so you don't fall and break something? If you'd have good lifestyle and lucky to have good genetics, don't fall between 65 and 100, and you might get farther along. So this salutogenic science is not something integrative medicine. This came around in 1950s. Aaron Antonovsky coined the term, and it's really a balance. I think we all believe both these things are really important. That actually, if you look back here, our healthcare system has the best return on investment from ages 65 to 75. And think of a knee replacement or some intervention that actually improves your quality of life. That usually has the most return on investment in this 65 to 75 age group. So that pathogenesis, that is not a bad thing. It's a good thing. We're just at 90% of that. We need to be at least 60-40 of salutogenic, proactive, active partnership, strength-focused, high value, really understands that there is no parts, that we're all this holistic complexity of things. And that requires this long-term investment of the roots of the tree that aren't easy. that aren't easy. So this is a balance that I think makes this a little bit easier, is that if most of our healthcare system is in on the reactive pathogenic, we don't have opportunity or the time to focus on these things. And I think we've talked about the importance of social determinants. If we're exploring a salutogenic model, we really need to understand the policies that allow people to get good nutrition, to be able to move, to be safe in their home, to have social support, to be able to do the things that most humans need to be healthy. That's the first ingredient. Then engagement. We call this a Wisconsin idea. How do we engage with our communities? How do we engage with our patients? How can they be responsible and understand with partnership what they can do with policy and support to be healthy? That's driven by meaning that generally influences behavior. And then we have this optimal potential, which scares me a little bit. Did you see this in the New York Times? This was just published a couple weeks ago. There are these tech companies that are experimenting with all these peptides. So glucagon-like peptide, GLP-1s, is a peptide that fools your body into thinking it just ate, right? A great drug. Now, pharmaceutical industry is creating all these new peptides that we can inject that influences our behavior. Oxytocin, for example, that I can inject oxytocin peptide, the love hormone, and actually it's being experimented in people with autism to increase their social connection. I think we should put the love hormone oxytocin in a blow dart and shoot our politicians. And maybe the world would be a little bit better. Sorry, I won't talk politics. But this is a little scary. This is not what I'm talking about. I'm not talking about biohacking the body with all these different peptides. I'm talking about basic things that stimulate self-healing mechanisms within the human body that facilitate a long health span. That's not, these might have a role. I'm sure we'll be exploring them into the future. Jerome Garrick, right there, my partner in the back, helped develop this when we were trying to figure out how do we talk about this business model in a different way. This is kind of what gets all of our attention, particularly in an academic, traditional fee-for-service. Relative value units means the sicker you are, the more I do, the more I make. We need that's okay. Actually, I think for our specialty and surgical colleagues, that's probably the best financial model. That's not the best financial for primary care. We actually want to flip that triangle on its head and really understand how we can make money keeping people healthy and out of the emergency room, out of urgent cares, out of those needs for acute and catastrophic care. And that requires people not even to enter the healthcare system. How do we do that? How do we engage people and communities to facilitate the salutogenic process without even having to enter? That works really good for a capitated model. Capitation means Quartz pays us a per member per month, $100 a month to take care of each Quartz member. And the healthier we keep them, the more profit we make because they're using those high expense interventions less. Does that make sense? So this is being done in spades. This needs to grow and we need a better balance. And we're exploring this with Quartz right now and other health payers. How do we do this? There was a study published in JAMA recently about all the value-based strategies with CMS, Centers for Medicare and Medicare, over the last 10 years. And they said they worked a little bit. They didn't work until 2 years out. 2 years out. No one is patient enough to do these for 2 years or more. So that's the long haul that we need to explore together. I'm a fan of Mother Teresa, who isn't, although someone close to her said she was a little difficult to get along with, but she was, she had autonomy. She said she would never march in a parade for war, against war. She would only march in a parade for peace, because a march for peace would end the war and prevent more wars from starting. That's what we're talking about. Marching for peace is salutogenesis. Marching against war doesn't really work. It might a little bit, but how do we shift that whole culture? This was way back in 2004. Our public health colleagues explored the eras of public health. Number one was combating communicable disease. We used to do that very well. Now we're taking a backslide. Dealing with chronic disease, which is the main thing that we deal with now in our healthcare system, are the diseases that have resulted from preventable things, frankly. The third era is to developing health to move toward a life a person wants. So meaning, what's that meaning? And this was the work that was so rewarding with the VA, is what do you want your health for? Drop a little bit deeper. And as we've said a number of times, we train the clinicians, but we forgot to train the veterans. We can't just train the clinicians, we have to train the patients or the people we're serving, because the veterans would come in and would ask, "Wait, what do you want your health for?" "Just give me my drugs. That's what you're here for," right? That was the culture that we set up. And we really had to train not only the clinicians, but also the veterans. And David and others have been involved in this movement for many, many years. All right, let's end with artificial intelligence, because this is affecting our lives in good and somewhat concerning ways. The best way, at least in my job, is I have this thing called ambient listening. I turn on, I ask permission, and I say, "This will listen and write my note for me." And the notes aren't as good as mine, I don't think, but I don't care. It saves me so much time that now I could do this. I'm gonna put that right there.
Hi.
Hey, and we could have that entanglement, that stuff that happens between two people where some newness grows. And so this technology is really going to expand, but it can never be human, can it? I keep saying that, but then I read all these studies about how the computer can look at your measurement of your iris and the dilation of your eyes and assess emotion, maybe better than our next generation who's doing this all the time, who hasn't developed that skill to read nonverbal cues. Maybe the computer will do that better by having all these sensors of the human face. I don't know. I truly believe there's something between us that is more authentic intelligence. And the thing I'm excited about is that these tools are going to allow us to be more human together. And that is exciting. These tools might also get in the way. There's this technology bias that if you do a large language model, that's the truth. But it's not. They have these hallucinations. And I'll share with a paper I just read over the break that talks about these hallucinations and compares artificial intelligence with the left brain. It's not that easy, but the left brain is the more analytical. It sees the train going by one car at a time. And the right brain sees it from above, sees where it's been and where it's going. And artificial intelligence is limited into that left brain. So what is it about that humanistic, that heartfelt right brain that really influences this care and influences the outcomes that we want? John Naisbitt said the most exciting breakthrough of the 21st century will not occur because of technology, but because of an expanding concept of what it means to be human. And this is a discussion I'd like to have together here in a few minutes, is what does it mean to be human? How do we bring this into this work in a way that really balances transactional care and transformational care? This is the article that, sometimes you read those articles that really make you have a shift or an aha moment. When I was trying to figure out how authentic intelligence is different than artificial intelligence, this paper by Christian Wyman, his dad was a primary care doc who became a psychiatrist. He teaches at Yale, and he wrote this great paper that I highly recommend about consciousness and that in-betweenness, he calls it. First of all, he talks about flow. In mindfulness teaching, we talk about being still. That's a really important thing, but there is no stillness. Everything is constantly in flow. The atoms in our body are constantly moving. As John Kabat-Zinn says, I remember doing this at one of his talks. What time is it? Oh, it's now. Now it's not. Everything is in flow, right? Everything's in flow. So we can never say there's one bit in time because it's constantly moving. And then he talks about this atom entanglement. I love this quantum mechanics because I'll never understand it, but it shows us the potential of what it means to be human together. That when we did that myofascial unwinding, that when you sit with another person and you feel the hairs go up on the back of your neck, when you experience that interconnectedness with nature, we're talking about atom entanglement. I remember we were at another retreat and we just went out in the woods. Usually, when you go out in nature, you look for nature, right? You sneak up on the animals. I saw a deer, saw a squirrel. Is that up? Squirrel. That's sometimes that's what we do. We went on this retreat and we just went and meditated in the woods. We went and we sat in silence. We opened our eyes. There were all these animals. What are they doing? And actually that energy attracted these other living beings within nature. So how can we be still or maybe in the flow with less physical movement where we can experience that beauty of betweenness? And this is the word. There's some words that just expand your, salutogenesis was one of those words for me when I was reading Aaron Antonovsky's work. My next one is betweenness. Betweenness. What happens between people? What magic that I'll never be able to understand or explain happens that makes us human together? And not only humans, but animals, trees, other things that have this atom entanglement. So that's what I'd like for us to explore and have ideas about together, because this is what rewards us. And it actually is the most sustaining things in regards to health and healing. When we would do our consults in our integrative medicine room, we'd experience tremendous healing events. When I would witness that, I would ask the patient to go and write down all the details, because you're going to forget. And you're slowly going to shift back to that place. Most humans do. Some retain some of it, but you don't retain it unless you realize what happened at that time. One of my favorite things when I'm sitting with someone who's depressed, tell me a time where things were going really well, where you were happy and at peace. What was going on there? What was going on in your life? Let's recreate that. Let's recreate that potential. And we do that through a trusting relationship that's not transactional, that's transformational. You seen Avatar? This is what I'm talking about. How do we connect to that universal energy that we're all connected to? And this is Hollywood's portrayal, but there's some beautiful truth to this. So this is our laboratory. The focus always goes to the big academic quaternary center on the hill, which is great. I'm so grateful to have our specialty colleagues and that expertise. We're the main referral center for our state, and we should be proud of that. And we have to maintain access for those conditions that really need our expertise. And this is a yes, and this needs to become more of our laboratory. How do we do this for our most vulnerable populations? How do we do this for each other in our communities to give everybody the basic needs that they need to self-heal? And that's our work. It may feel like it hasn't changed in 25 years, but it has. It has. Thanks to you all. Thanks for the work you're doing. I'm so grateful for my 186 primary care colleagues out in our 18 clinics throughout Wisconsin, because this is the work that we do every day.